did, and then we'll have you guys, drop out and then play the video.
All right, so first, glad everybody made it back from the break. That's always a good thing, right? So this video is very near and dear to my heart. And the reason why is because, number one, it deals with my son. But number two, it highlights something that I think has become a problem we've had in medicine, right? I'll set the video up a little bit, and some of it I'll mention in the video itself. But so, here I am, dad, super dad here. My son's on the road to recovery. He's done really well now. It's the first time mom decides, I'm going to go take a trip without you guys. If you're a parent, you understand. I'm going to leave my baby. Wait a minute, we had this baby together. I'm going to leave my baby with you. Don't mess this up. And so he and I are together, and we're excited because it's the boys. We're hanging out. It's the boys. Oh, yeah, me and the boy. And so I didn't know a lot about sepsis, but I'm glad I acted quickly. And Armando's got an amazing story in this as well. And so if you've never heard his story before, it's powerful. It is absolutely powerful to hear what he goes through with his son and his story as a whole. But the video itself, it speaks for itself. And I have a couple comments I'll make at the end of the video. So if you guys would do that. You know, that is, I've seen that video hundreds of times. And it makes me think every single time, things could have been different for my son. Things could have been different for Armando's son. It's interesting, I went to, I work in the Pentagon, and so it's a pretty large building, and it's like a little city. And we've got everything you want in the Pentagon, from a DMV even, and certainly we have a clinic, the clinic. A DMV is very helpful. But I remember going to the clinic in the Pentagon one day, and this is after MedStar had kicked off a campaign to really address sepsis, right? Because one of the things that I had a lack of knowledge about sepsis. I'd never heard of sepsis, certainly by the name and the term sepsis. I knew people got sick and they had blood infections, but I didn't really know the term sepsis. And I had a lack of information about sepsis. So when I got to the Pentagon one day, I'm in the clinic and I'm talking to one of the nurses down there, and we were talking about, I think it was in March, actually, so this is pretty recent. It's in March. We're talking about, I think it was safety, patient safety or something like that. And I said, hey, guys, what's your protocol for sepsis? Easy question. What's your protocol for sepsis? And she says, well, you know, we've got our hand washing stations that are here. And I'm saying, you know, in my mind, I'm doing that look you had on your face is the same thing I had going on in my mind, like, oh my God, if you don't have one, just tell me you don't have one, right? We've got the hand washing stations that we're encouraging people to go use. Data point. I do a lot of cooking at home for my wife and my son, and certainly since he has galactosemia, I've learned to make a lot of things that don't have dairy in them or substitute dairy. So I do a lot of cooking, and one day I'm making something, and don't ever cook when you're angry. Let me just put that out there. So I think there may have been something on the floor because, you know, when dads cook, there are dishes that get messed up, and my wife comes down and she says, don't cook while you're angry. Just remember that. And I cut my finger. I would have cleaned the dishes up. I'm just saying. I mean, I cut my finger, and I go to the hospital. It was a pretty deep cut. And I'm talking to the nurse that's in the hospital at the military hospital. And I'm just sitting there, and I said, hey, what do you guys do for sepsis? What's your sepsis protocol for patients that come into the ED? And he says, I don't know that we have one. We do training for our physicians. We do training for the guys that are in the hospital to recognize sepsis, but I don't think we do one for the ED. Data point. And so it made me say, we've got to address this. And I went back to my office, and I'm talking about sepsis. Again, I've seen this video hundreds of times. And I'm talking to one of my fellow guys as a major, and he says, hey, you know, I think I may have had sepsis at one time. I said, well, what's your story? He said, well, hey, I was sick. I was in this kind of remote base in Arizona, and I got sick, and I go into the hospital, and I'm sitting there in the ED, and I'm really feeling bad. I'm sweating, I'm shivering, I'm cold, but I've got a temperature. And they send me down to my primary care person, PCM, to go look at me, who sends me back to the ED, and I'm shuffled back and forth between two offices because we don't have a real protocol to deal with this, and we don't understand the signs and the symptoms of sepsis. And he actually collapsed in the ED. Wow. Push pause on life and put that in your mind. You're sitting in the hospital, the place that you come for security, for safety. I feel like I can be helped and healed, and you fall out in the hallway because you've made 2 trips between 2 different offices because people weren't talking, and the real reason was, the root cause was, we didn't have a protocol to address sepsis. So it's a very powerful video, and it also exposed a seam or a gap. So we talk about those learning, that paradigm shift, that learning opportunities. And so now I'm working with the DOD and the Department of Health, Health Agency, Defense Health Agency rather, to figure out how do we establish a link or partnership with maybe MedStar here to address sepsis across the entire Department of Defense and the Defense Health Agency. But that was only identified because I noticed a seam that we didn't have a protocol. That was not something on our checklist. And there's the paradigm shift that we have to always kind of go back to. The last two things I'll just say. There's a guy named Alfonso Chapanes. Probably never heard of him, but in the aviation community, he is huge. So back in World War II, they had B-17 aircraft, and they crashed a lot. And the reason why they were crashing is because of pilot error. So remember we say we don't want to go blame the pilot? It's a system thing. During the break, I was talking, and I said, hey, I was talking with someone, and I said, in the military, it's not all about the person. It's about the system. You can take an average person of average intelligence, and I hate to kind of put it that way, but ability, and put them in a perfect system and always get a perfect product. It's the process. I can take a perfect person who thinks they're perfect, put them in a really messed up process, and I will never get a perfect product. Why? It's the process. It's the process. So Alfonso was this guy who says, we have all these B-17 planes that are crashing at takeoff and landing. Why is that? Are the pilots that bad? Well, no, they're doing good stuff fighting the world war here. It can't be that bad. And what we discovered is that they were mixing up the landing gear and the flaps on the wing to reduce the air flow so that you could slow down and brake and land. They're mixing them up because they're in the cockpit. They're right beside each other. So you're grabbing the wrong thing. Think oxygen and nitrous oxide. Think gasoline and diesel. So what did he do? Something really simple. Human factors coming into play here. You put a wheel on the landing gear. You put a triangle on the wing flaps. Greatly reduced airplane crashes. And oh, by the way, we still use that today. Looking at those things, kind of those human factors, looking at those common sense approaches, looking at that thing and saying, it's not about that person, it's about the process, it's about a checklist. It's looking and changing that paradigm shift is one of the things that we had. Last thing I'll say is that simply, as a dad who's gone through some real traumatic stuff with his son, first of all, he's a resilient boy, really resilient. But what helps me have my resilience is having that physician, having that doctor inspire and give me hope. And they give me hope because they're transparent. They tell me, we're trying to figure this out. Here's what we think it might be. But they've built a culture, certainly at Georgetown, I speak from experience there, built a culture that we're not afraid to fail. And that's a hard culture to establish in the medical community. That's a hard culture that we had to establish in the military, that it's okay to fail. There's a lot of learning that happens through failure, but you've got to change the mindset to address that learning. All right. Yes, sir.
So now, sorry. So how are you guys now pushing out and using the video? Because we didn't quite get to that, because this is it's part of community outreach, as I understand it, and other stuff.
It is, and I'll tell you guys, I was mentioning in a break, I have so many thoughts that are like going on in my head and just data points, so thank you for bringing it back. So one of the things that we're doing, beyond just having this video posted on social media, and the last time I checked it had been viewed over 5,000 times, we've got campaigns that we're reaching out into the community. So I've seen it on the news. There's the little commercial they put on the news. That's information. I've seen it where we would go into other organizations and they would host us and we would send a team. We've got sort of like a go team, if you will, like 3 or 4 people that would sit on this team and go out and talk about sepsis to church groups, to fraternal organizations and sororities, to military organizations. I think we did a couple community projects, and one of the focuses was talking about sepsis. And so those are the kinds of outreach things that are really simple, that are really inexpensive and somewhat organic. People volunteering their time. You'd be amazed at how much time people want to volunteer to come do things. And I think a lot of times hospitals shy away because they're like, oh, I don't want to have to pay somebody to go do this. Well, you'd be amazed at the number of people on staff and community members that want to do stuff. They just have to be asked.
Awesome. Yeah, they do just such incredible work, and thanks for sharing that. So now we're going to go back to our event, and I'm so glad you mentioned protocol, Stephen, because it's going to come up a little bit, hopefully, depending on how all the interviews go. But so the goal, and Kelly mentioned this, cognitive interviewing, it really became popular in law enforcement. But now it is being seen to be so valuable, it is actually integrated into all the work that's done in the NHS when they do event review. everybody's trained in how to do it now there as they begin to. And it really is, as Kelly mentioned, a way to enhance recall of people and do it in a way where we're not leading them, where we are being very careful, again, of our own biases when we go about doing this, because you really want to be careful with that, because often the interviewee wants to please you. So if you're going down a certain pathway, they'll often just go along with you. One, they're nervous about the interview and doing that. So it's really important to make sure that you're not there. So now we're going to do an exercise on purpose. These are not in your slides, so don't look at them. So quickly, I'm going to show you, get a piece of paper and pen out. I'm very quickly going to show you some pictures, and I want you to, over the course, and I'll pause in between of them, but I want you to write down what you think you see. Okay? And we're going to go through sort of a bunch of these. So, first one, I'll write down, what you thought you saw. Okay? Next one. Okay, let's do it again. All right?
How many were there?
Yep, should be 10. So this gets, again, back to what Kelly was saying, which is, pausing, reflecting, no judgment, being careful with that. So what do you see here? Horse, right. And then, did you notice, though, that those first two pictures were the same, just oriented differently? And so this is the part of the meeting I love it, because so many of you just turned your head so that you can look at it this way. So yeah, so the one was, you probably wrote down frog, and the other's horse, and that's kind of what they are. But they actually are the identical picture. They're just rotated on the slide. Wow. Absolutely identical. So this gets to context. And this is what Kelly was saying is, when you do event review, sometimes you want to go to the event in the middle and then beyond. Sometimes what we'll recommend people to do is to say, imagine you're somebody else in the room watching this happening. What would you see if you were here, there, or the other? So and again, I really love what Kelly said is, what was the lighting in the room? Where were you? Where was the patient? All that sort of stuff. What did you smell? What did you eat? What are all those things so you can really get them back in that point in time? So what about this? What did you see? Yeah, and you see it's really not a skeleton. There's a boat hanging up above. There's a fence that's there. There's all that stuff. But again, on first glance, most people often think it's a skull. How about this? So show of hands, who saw two faces? Who saw the chalice? Yeah, well, that's good. The fact that you quickly see both. This is a common picture. A lot of people have seen it before, but it's kind of a neat one to do. How about this one? So does everybody see the young girl and the witch? Okay, because a lot of times it's a little hard. Matt, do you see both? Okay, good. And then the same, of course, goes with this one here, right? Do you see both again? Which one can you only see? The young woman. So the old woman, so a lot of people do just see the young woman's nose and their hat and their ear. The old woman, this is the eye, that's the mouth, and that's the chin. And so again, so this is looking at events again from kind of a different angle and keeping your mind open to what some of the things are that are there. Same picture, right? One's upside down, the other isn't. Again, some don't quite see that. And how about here? It's a sax player and a face, okay, where again, depending on how you're looking at it, what you're there. One of the things, and I don't have these up, I may add them one of the other times. There's a, Brian Sexton did a study showing that when you show up some of these pictures, depending on the kind of music you've listened to, just prior to looking at them, you see something different. So there's one picture that's either a squirrel or an alligator. And if you play really gloomy music, like the theme from Jaws, you always see the alligator. But if you play really nice music, you see the squirrel. So again, your mood, when you go in and do some of these interviews, is super critical for doing that. How about here? What do you see? You don't see the word? Come on. Whoops. Yeah, so same thing. If you turn your head to the side, it's actually a word. Now, here's one, and Stephen, I'm not going to have you do this with Deuce, but there's some data around it. So a lot of people, when they see this, they see an intimate embrace, all right? They don't see the fact that it's 9 dolphins. And when you look carefully, you see these are the dolphins that are in there. They are just arranged in that way to look like this. But if you look really carefully, these are just dolphins. You know, where there's a dolphin here, there's a dolphin there. There's just dolphins. Now here, Stephen, what's interesting is, and again, he's 5 and he's a bright kid. When you show this to 3 or 4-year-olds, they can't see the embrace. They only see the dolphins. It's just fascinating that your experiences influence the way, you know, that we often see things. And I love going through this because it's Kelly, like you said, okay, you know, it's an allergy. They gave the drug. That must have done it. So you go in with preconceived notions in like the case that you mentioned for that. So age and context make a difference. So why talk about bias? The other reason is we often have so much hindsight bias that we know what happened. And so the goal of cognitive interviewing is to get into the tunnel, just like Kelly said, which is try to identify at the time what happened and why it made sense to them at the time to do it instead of going, WTF? You did what? I mean, I will tell you in our Office of Safety and Risk Management, you would hear that at least 10 times a day. You know, a case comes in, somebody screams from their office, are you effing kidding me? Did they really do that? But then they calm down, they do a little yoga, then they would go up there. No, really, because it's you guys know how that is. It's like, I'm going to get in there. It's going to be really hard not to be judgmental. But that's really the key about it. And so how many of you are familiar with Brené Brown? Remember we showed the empathy, sympathy video at the last one? Have you seen her one on blame? I love this one on blame because she talks a little bit about water polo. My kids played water polo. So why don't you go ahead and play this video? Because, again, it gets to what we want to avoid doing.
How many of you are blamers? How many of you, when something goes wrong, the first thing you want to know is whose fault it is? Hi, my name is Brené. I am a blamer. Let me just tell you this quick story. So this is a couple years ago when I first realized the magnitude to which I blame. I'm in my house. I have on white slacks and a pink sweater set, and I'm drinking a cup of coffee in my kitchen. It's a full cup of coffee. I drop it on the tile floor. It goes into a million pieces, splashes up all over me. And a millisecond after it hit the floor, right out of my mouth is this: damn you, Steve.
There you go, Steve. I played this for you.
Here's my husband. Because let me tell you how fast this works for me. So Steve plays water polo with a group of friends. And the night before, he went to go play water polo. And I said, hey, make sure you come back at 10, because, I can never fall asleep until you're home. And he got back like at 10:30. And so I went to bed a little bit later than I thought. Ergo, my second cup of coffee that I probably would not be having had he come home when we discussed. Therefore, and so the rest of that story is I'm cleaning up the kitchen, Steve calls, caller ID. I'm like, hey. He's like, hey, what's going on, babe? What's going on? So I'll tell you exactly what's going on. I'm cleaning up the coffee that spilled all, like dial tone. Because he knows. How many of you go to that place when something bad happens, the first thing you want to know is whose fault is it? I'd rather it be my fault than no one's fault. Because why? Why? Because it gives us some semblance of control. But here, if you enjoy blaming, this is where you should stick your fingers in your ear and do the na thing, because I'm getting ready to ruin it for you. Because here's what we know from the research. Blame is simply the discharging of discomfort and pain. It has an inverse relationship with accountability. Accountability, by definition, is a vulnerable process. It means me calling you and saying, hey, my feelings were really hurt about this, and talking. It's not blaming. Blaming is simply a way that we discharge anger. People who blame a lot seldom have the tenacity and grit to actually hold people accountable, because we expend all of our energy raging for 15 seconds and figuring out whose fault something is. And blaming is very corrosive in relationships, and it's one of the reasons we miss our opportunities for empathy. Because when something happens and we're hearing a story, we're not really listening. We're in the place where I was, making the connections as quickly as we can about whose fault something was.
I love her. And you know, these are all easy to get. You just do Brene Brown, YouTube it. She's got a bunch of them. She's got a beautiful, I think it's a TED Talk on vulnerability. I really recommend to you all. You know, as we move through these workshops, I think the vulnerability one is a really good one to Kate for kind of like homework. You know, particularly as we get into resolution. Because remember, resolution isn't just money, right? We're going to talk a lot about the non-financial pieces and the other stuff sort of related to that. So it's just crazy. So anyway, when you do the interrogation, this is where people will clam down. These actors will not tell you anything if you take an interrogative mode. You know, if they don't feel it's psychologically safe to be up there with you, talking to you, you're not going to get much information. And actually, it also disrupts the normal memory process and stuff when we do that. So this cognitive interviewing goes by many names. The one I kind of like is sort of conversation management, you know, as well, in terms of what our approach should be. And we know there's tons and tons of studies now showing that when you go in here and you have these open-ended questions, you get much more information. Can somebody give me an example of the difference between a closed-ended question and an open-ended question? Give me just what comes to your mind right away. Ask me a closed-ended question. No. But yeah, that's closed. It's just yes or no. Can I help you find anything? What's that? No, I didn't. I only ate a little fruit. I'm really hungry. Yeah. So what's an open-ended question? Please tell me more about that. What would be another kind of open-ended one going along with what people said? Tell me what you've done since you woke up this morning. That's an open-ended question. You know, Kelly used the phrase, remember what she said? Tell me more. I mean, that was the best open-ended question, Kelly, you could put up there in the context of this. It's very simple. It's just tell me more. Versus, you know, did you pull the line out? Did you apply pressure? Did you follow the procedure? All that stuff, those are going to be close-ended. And I'm warning you, those of you who are at the last workshop, I'm warning you to be careful with those kind of questions, because you know how the actors are. So anyway, one of the other things that you want to do is develop rapport. I thought Columbo was great at that. I don't know how many of you remember that show, but he was awesome. And he just would sneak right in there. He was like a Southern guy, too, Steve, that could get in there, and all of a sudden you think they're the best friend, but he's just planning to really get all the information. And again, ask these neutral, the non-leading questions, stick with the open-ended, and there's sort of a sequence. I totally agree with you, Kelly. So part of this is you introduce, you set expectations. You know, here's why it is we're here. And what often we would say is, you know how you say take notes? Review them. It's kind of like teach back. Here's what I wrote down, what I heard from you. I want to make sure I got this right. And that helps develop trust, because now they know you're not making assumptions or putting stuff in there. You're trying to do that. And then, again, you want to preserve the ongoing dialogue, right? Because you may need to come back and say, oh, you know, we've learned a little bit more, so you really want to do this. And again, one of my questions would be, in your organizations, who does the interviews? Who does the interviewing in general right now?
For us, it's usually the person who's most comfortable interviewing. So somebody who doesn't provide you direct patient care in the area that's affected, but has some comfort with just interviewing people and doesn't know much about the process.
How about others in terms of who you have that will do some of the interviewing? Just curious. Do managers ever interview frontline people? That's tricky. I'm going to suggest, Kelly would suggest, try to avoid that. Because they're often very afraid of what they're going to say, especially when they ask the question of, did you follow our policy that everybody else follows on this unit? You did follow the policy, right, that everybody follows on this unit, and you just end up going right down a pathway you don't want to. So I tend to agree with you. We totally got away from using direct supervisors to do interviews. I mean, they need to talk to them for their purposes, not for event review in general. So I think that's another piece of it. And if you can, you don't want to interrupt when they're on a roll and they're telling their story. And then, of course, I do love using sketches and diagrams and any kind of prop I can use, because it's much easier for me if they're hanging on to something and showing me what it is instead of trying to. I'm visual, and so I think it's very helpful for me, because in my mind, I'm also thinking that's going to be easier to explain to the family. Because often they like props and sketches and other stuff, because like, you know, Stephen said, there's not some of this stuff is clinically complicated. And we already talked about this piece that Kelly brought up. This is just a reference to the NHS. They are doing tons and tons and tons of more and more of this kind of work, and it really is an expectation where their hospitals have clearly identified people who are comfortable interviewing, who they can pull in on any of these. So back to the case. So you've got the chart, you have this piece. What I want you to do at your tables is, for about 5 minutes, talk about the kinds of information that you would want to be able to get from the nurse who was with the physician when the line got pulled. Okay? So take 5 minutes at your table, kind of talk about that. And then remember the rules at the last workshop? No one has to go up on the stage, you know, to have the conversation. Anybody at the table can opt out. If you don't want to do it, it's something you would hate to do. Just make sure you tell people at your table. But at some point, we would like for you to even begin to think about somebody who's willing to volunteer, and maybe we'll have more than one, to interview the nurse to see if we can get as much information as possible. So for 5 minutes, do that. Think about at your table who you might want to have come up and do it, and then I'll have our nurse come up shortly. Okay, so do we have a volunteer? You do? I heard somebody say, yeah. That was perfect. Oh. So do we have a volunteer? Again, the setting is before the patient's died, but after the cardiac arrest, and they've been transferred to the other hospital. Okay? Perfect. Thank you so much. So I'm going to, what did I do with it? I had the handheld. Is it there? Perfect. So Dar? Yeah, so I'm going to have you, hold the handheld.
You can tell I'm an idiot and an extrovert.
No. Hang on.
I don't know what I'm doing, but I don't care.
Before you get going, just a few more things.
Sure.
First of all, let's give it up for Dar, who has volunteered. Because this is not easy, okay? The other part, for purposes of the enactment, Ryan. You guys work in the same hospital. He knows you. He knows the purpose of why, again, you're meeting with him here. As I mentioned, it's after the cardiac arrest, but it's before the patient's passed away. I think that's pretty much it. So we will go ahead.
Hi, Ryan.
Hi, Dar.
How are you doing?
I'm doing all right.
Yeah. So we've had a bit of a challenge today, huh?
Yeah.
I'm here really just to learn about what happened, and I have to tell you, I just had a dental procedure done, and I've got a bit of a lisp. Okay? So if you can't understand me, go ahead and ask.
Okay.
All right?
I will.
This isn't to get anybody in trouble, but I just want to have a conversation with you, and I want to learn what happened today. And I suspect that you'll be a good help for me in helping me understand that. I've asked Sarah to join us because I want Sarah to take notes. I want to focus on our conversation, but it's important that we have some notes for today too. And we'll review those notes with you at the end. And so I'm not distracted by writing as you're talking, but Sarah will be doing some writing.
Okay.
And I don't want you to be distracted by that either.
Sure.
Okay?
Yeah.
So just generally, what have you heard about today, and what do you know about today?
I've just heard that I was helping pull out a line, and that the patient went into a unexpected cardiac arrest, and that's all I really know about the situation right now.
Okay. So what do you think happened?
I don't know.
Okay.
I don't know how it got to that point. I was just doing my job.
Okay.
And just, yeah.
Ryan, you've been a part of our team now for a long time, and you're an awesome nurse. You're just one of the best, and so I really respect your thoughtfulness and your judgment as we kind of think through what might have occurred.
Yeah.
I'm really interested in, had you seen the patient before the procedure today? Or when's the first time that you saw
Today.
Our patient? Today?
Yeah.
Okay.
This isn't something I am normally doing.
Okay.
So it felt a little odd to be in the room, honestly. So I've never seen the patient before. I've not done work like this, of pulling out a line, so I felt a little bit out of my element.
Okay.
In that sense.
Okay. So what's your role normally look like? What do you normally do for us?
Well, I'm not, like I said, I'm not usually doing things like this as far as pulling lines out. I feel like I'm normally assigned my patients, and I stick to those patients, and that's my day-to-day. And this was something that was out of the ordinary, and the event kind of goes along with that. It's just not something I've experienced before.
Okay. So how many patients did you have today, Ryan?
Honestly, I can't even give you the number. I feel like, as you know, it's just a lot going on, and we're understaffed. And that's what is a little bit hard about this, is that I'm spreading myself really thin. I'm going as fast as I can and trying to be as on top of things as possible. But I can't even give you a number.
Okay. So it sounds like today was a little chaotic on the unit.
Yeah, and it's not just today. I feel like it's been recently spread thin. And it's like, as soon as I'm finishing one thing, I feel like I'm late for the next, or just, I can't keep up.
Okay. That's important for me to hear, Ryan, and I don't want to lose sight of that, so I do want to come back to that, and I think we'll probably have a discussion at a later time. I want to schedule something with you, though, to follow up on that. Okay?
Sure.
So don't let me lose sight of that, and before we leave today, we'll come out of here with an appointment to follow up, because I really do want to listen to what's going on with staffing.
Okay.
I'm really concerned about that.
I am too.
Okay, so back to today. We're talking about Mrs. Jones, and it's the first time that you saw her, and that, refresh me again. What was your role with her again?
I really had no relationship with the patient. The resident asked me if I would be available. I'm sorry.
That's okay, I'm just so sorry. Would you like a tissue, Ryan?
I think I'm okay.
Okay, take your time.
Asked if I was available to help pull out this line, and I had seen him. I know him. Don't know him too well, but he's got a really good energy about him, and I like him, so I wanted to offer my assistance. And it was so fast. I didn't think I was going to have to be there too long, and then I got called away, and I just thought it was another just routine, that everything went according to plan. It wasn't until after that I found out something went wrong, and I don't know what went wrong.
Okay, okay. So, you know, you're a really good nurse, and I think that's probably why the resident pulled you in to help. So thank you for that. You know, I really do appreciate all you do here for our team. As we think about that, or as you think about that, you've never pulled a line before like this. I think I heard you say that.
I can't even
Talk to me a little more about that.
I honestly can't even remember training on it.
Okay.
I thought I was just going to be there for more just support, opening things as he needed, and just to be the other body in the room. But I'm really unfamiliar with the procedure and didn't feel like I needed to voice that at the time.
Okay.
But now I clearly should have maybe said something.
Okay. You know, Ryan, I haven't pulled a line, honestly, for years, probably decades, since I pulled a central line. So how did you go about doing it? What happened?
Well, he sort of asked me in between things as he caught me, I need help with this, and I was like, yeah, I think I could do that. So I came into the room. He had all of the things he was going to need on his table. I was standing behind him, and I just did what he told me to do. I opened up all the equipment, the gauze, and it just seemed so routine and simple, like nothing flagged, like nothing is like, oh, that's where things went wrong. Like I don't have that memory of something happening, like an event in it.
That's fine. You know, there may not have been an event with this, so I want to hear about all the things that went right. Can you tell me the steps?
So I removed the gauze for him. I remember that. I remember she was laying down. I remember him applying pressure. And then I got paged, and I said, I need to go. Is that okay? Do you need me anymore? And he said no. And so I left.
Okay.
I was also really close to a shift change, and you know how that goes. I'm just trying to get everything done that I need to, and maybe I should have said no to fitting this in, but I didn't. I thought I could help. I wanted to help.
Sounds like you did help, so thank you.
I'm not sure if I did.
So let's go back to when you first entered the room. Was the patient awake?
Yeah.
Okay, and I asked a really narrow question there, but just generally, from a Socratic method, maybe talk to me about what the patient looked like.
Was
she in bed?
She seemed really good.
Okay. What does really good look like?
Happy, in good spirits, healthy.
Okay.
She looked good.
Okay, great.
Yeah.
Can you describe for me any assessment that you may have made on her?
Honestly, I just feel like I was there for him, and it wasn't my patient, and I didn't have that connection in that way. I just wanted to be that extra pair of hands.
Sure. Great.
I kind of only feel that connection now that I know something's gone wrong. I can just picture her face.
Okay. So go back to the room. Who all was in the room?
It was just the three of us in the room.
And the three of us were specifically?
The resident, the patient, and myself.
Okay. Did you use a pack, or did you have to gather supplies?
It was all there.
Everything was there.
He had it all set up.
And it was all set up. Okay.
It's all ready to go.
Okay. So, again, the resident had everything set up in the room, and as you walked in, the patient was awake. She was talking. I'm just trying to rephrase here, get a feel in my mind for what things look like. Okay.
So why don't we stop it there? That was amazing in terms of the information that you were able to get out there. I'm wondering, Kelly, if you would come up now, because maybe we can start writing down some of the, so from your perspective, you clearly had a plan when you went in. Can you share with the group kind of what was going through your head and what your goals were?
I wanted to learn what normally occurs, and clearly, I think from Ryan's perspective, I'm not going to find that out. But I do want to follow up with Ryan because he indicated that we were really short-staffed, and this wasn't the first time. So I want to make sure I get a parking lot of issues to address, and I've asked him to help remind me at the end of this interview that we want to set up an appointment for that. I just want to know what was the prior patient, what did she look like when he walked into the room, and had he conducted an assessment? And not that I have anything against him not having done so, I just want to know if he did. Did we have a set of vitals beforehand? Was she awake, alert, and conversant? What was the environment like? Who else was in the room? Who might we want to reach out to? And I haven't gotten quite to that yet. What does he know about the procedure, and what steps did he perform? Not what should have been done yet, because I can find that out later, but what exactly did he do, and what did the resident do, and who else was in the room? So let me think what else. I want to find out, let's see. One question I haven't asked him yet is there anything that I haven't asked you that you wish I would? What would you like me to know that I haven't asked about yet? And who else should I talk to? I want to know what he think happened, if he has an opinion, because sometimes nurses do have an opinion. And I want to know what he's heard before our conversation. So, in our hospitals, news like this travels like wildfire. There's usually a little bit of speculation going on behind the scenes, so I want to be aware of that. And then actually, I would intend to close with him on a reiteration of the notes, kind of a review of what we've talked about, a plan to follow up, and a way for him to let me know if he has anything that we haven't covered that he thinks about later that may or may not be important. And
were you thinking about asking about the note and why he had written in the note
Yep, but I haven't gotten
That
there
was
yet.
okay.
Yeah, I just kind of wanted to close with some
Okay.
of that and then say, okay, let's look at your documentation real quick.
Great.
You know, just help me with that. I'm, you know, not very good with the medical records, so help me find your way through. And in this case, I maybe don't even have access to the record. I don't know, but
Okay.
have them walk me through that.
Yeah. So the key, Ryan, is getting into a comfort zone, feeling comfortable. Can you share a little bit about how you were feeling emotionally when she came in? And
Yeah, I think
because you volunteered a lot of information.
Yeah, I did.
And so share a little bit about what maybe she did or how you felt, you know, with that part.
Yeah, you have a really supportive energy and language about you. So I felt really comfortable.
Wait a minute. Are we not agreeing with that over
Looking
here?
at my team and going, hey.
Oh, yeah. Well, yeah, the actors will make you do that, that's for sure.
Where, not that I have a plan when I come up here, but I definitely would not have shared things with you if I didn't feel comfortable. So it was not, you had to earn all the information, because the thing that we didn't really get to yet is that I'm really worried about my job at this moment. But you were talking me, kind of giving my ego a little bit of a hug of like, I've known you for this long, and this is the first time we've sat down and had to have a conversation like this. Like, it's okay. You want to help. So allowing me to sort of take a step back. You said it happened today, so it was kind of like, okay, this interview happened immediately. It wasn't a day, it wasn't 2 days. So trying to recall as much, because I could tell you were here to help. I did not feel like I was being interviewed or
Interrogated.
Thank you, that's the word I was looking for. I did not feel like
Great.
I was being interrogated. And yeah, that you've got a really warm. It reminded me of like sitting down and talking with a family member, like one of my family members. And that's why I think that emotion started to come up, is because you were open to receiving that.
That's cool. So let's go through. You probably wrote a lot of notes down. I've got Kelly up at the flip chart here. Let's just throw out some things you heard that are now very important that you didn't know before the interview. Really important stuff. What's that?
Not his normal job. Never done it before.
Not his normal job. In fact, she was never going to get what do you usually do because he's never done it before. Yep. So, and
Staffing.
what's that? Oh, somebody said something over here. Hang on. Ready? You sure? No. Oh. You got it.
He did not know the patient.
Yep. Right.
So he didn't have a patient.
Didn't know the patient, so doesn't know the baseline.
But honestly, her baseline was awake, alert, having a great time,
She was.
communicative.
Yeah.
You know,
Probably excited
so
she's going home.
that's kinda critical.
Over. You can throw that to me. I love throwing this thing. Are you ready?
He said he was paged away while he was holding pressure.
Oh, yeah. Did everybody hear that? Paged away in the middle of the procedure, right when he's starting to hold pressure.
Yep.
That's interesting.
Oh, yeah.
He also said it was at the end of his shift,
Mm-hmm.
and he was
Change of shift. Kate.
Yeah, change of shift.
Yeah.
Change of shift. What else did we hear that was?
A little chaotic on the unit, and staffing was an issue, and that sounded like that was kind of a chronic problem.
Mm-hmm. Yep. Which is in the parking lot now,
Yep.
right? That we have. Other.
Not something that he ordinarily does or is used to doing or has experience with. It was just something
Right.
that
So no experience. Hadn't done before. What else did he say? What's that? Out of his element,
Out of his element.
and no training.
right.
You know, if all of that stuff is what's that?
He reiterated that.
That's right. He reiterated a few times. Yep.
Yep. Resident
Yep.
he knows and trusts.
Yep.
Yep.
I like him, so I'm going to try and help him out.
Yep.
Right. Yeah. Yep. Anything else that you picked up?
Everything was in the room. That's kind of important because he didn't have to run grab something. So we're we're not asking an inexperienced nurse to go grab something that they don't know what they're getting. So it was in the room and set up, ready to go.
Yep.
So from an equipment standpoint, we're probably less concerned.
I'm also thinking about his emotional state and that he was seeing the patient's face and very emotional about that. So I'm wondering if we are going to tend to that and how.
Well, so you were at the last workshop. How would you tend to this? What would you do after this interview?
So I get him off at, for sure, his next shift,
Yes.
offer EAP, and then actually offer to accompany him for that first appointment or help him make that first appointment, because that's a scary thing too for people, is to let them know it's completely confidential and really non-threatening, but really, really important. And it's so important that I'm willing to escort him there if he needs to be. I'll help him make that appointment, get him time off as he needs it. So.
Yeah. The how about from the last workshop? What might people think about? Yeah, here. Yep.
But she could have, and it probably would have been very disarming. He said it felt like she was just here to help. And so one good approach would be, hi, I'm such and such. I'm here to find some information out. I'm just here to help you, which is what she did, because she stroked his ego enough to make him feel less bad about himself and a lot of other supportive things. So I think that's a real good way to approach it.
Yeah.
So it seems less that it's an interrogation.
Yeah.
First moment too, like the first meeting, the first words that are exchanged will play out how the rest of the interview goes. Like you have that moment, even if we know each other, to sort of establish part of the ground rules and what you can expect. And you laid it all out of like, we're going to do this, and I already want you to know I'm going to follow up with you on this. So that kind of gave me a breath right away.
From a culture perspective, what is one other question that in this situation sometimes can be asked that might be useful? Well, so, and that he's certainly worried about. Where I'm kind of going at is...
I'm here to learn about what happened and not any mistakes that you made, or you know, anything that you say isn't going to be held against you at this point. We just want to help improve our processes.
Yeah, one of my, and this is almost close-ended, would be, and I try to open it up to say, you know, when you're working on the unit and you feel like things are out of control, do you feel comfortable, you know, stopping the line, you know, doing that? You know, because that's the big culture issue here is, you know, he's clearly, this is chaotic. He's over his skis. Normally we often try to teach people, hey, raise your hand if you're uncomfortable doing that. That's the other piece. And I can answer that for him in the real case, which is no, the culture wasn't where people felt they could stop the line. So you can add that piece there.
It's a good one. Yeah.
So any other observations that we want to make sure that Kelly writes down here? Because again, we're just gathering lots of information. As you can imagine now with what you know, how interesting it's going to be to meet with a junior physician. You know what I mean, who comes up. Now that you know way much more, and think about what's not in the chart. You know, leaving the room, getting paged away, you know, all that sort of stuff. And there's just 3 of them. So there's nobody else. If you want to really know what happened in that room at that time to interview, I thought that was great to really clarify that, to say, you know, who all was there. That was really good. Well, let's give it, go ahead.
And I'm probably going to close it, too, to ask Ryan to just help me protect the reputation of not only Ryan in our unit, but our organization. So let's keep this confidential and don't have any discussions outside of this room or outside of with me at this point. We're still gaining information and gathering information, and you're definitely an important part of that, but don't want anything that will say or do that will harm either your reputation or the reputation of the organization at this point.
Yeah, so to revisit the last workshop, you know, a lot of organizations are putting together peer support or care for the caregiver programs. Have any of you started to begin to look at that a little bit in terms of that part? Because what often people would say at this point is, but I do want to let you know, we do have this process in place in our organization beyond EAP. You know, we're going to have somebody reach out, just make sure you're okay. It's just, when you do have that conversation, it's going to be about supporting you and doing that and not necessarily talking about the event or the other part of it. But I do, this in the real case, this is the point where we activated the Care for the Caregiver program like crazy, you know, for everybody.
We haven't done that yet, and I'm interested in doing that, I guess. Hoping that we can do that as a network.
Well, and
initiative.
again, we'll talk more about that this afternoon when we get operationalizing. But remember, this is the go team concept of the big three. You know, in your mind, you're thinking, this is event review, but I got two other big important things as part of the organization, communicating to the family and supporting the people involved here. So again, that's why we're going. But let's give it up for Dar again doing that stuff, and Matt. And yep. So now take another 5 minutes and think about, in that context, the interview of the junior doctor who will be coming up here in a few minutes. And again, it'd be lovely to get somebody to volunteer again. Thank you again for volunteering to do that. Okay. Our junior doctor is going up there just to re-ground everybody. In this situation with you all, it is actually not a resident physician. It's a junior physician, and you can find out how junior when you have a chance. But they're actually not a resident that you're going to be interviewing up there to do this. It's a junior, still a junior physician. It is not a resident. Okay. An attending who's been out for a year. Somebody who's junior, really young. But that, again, that's part of what you'll be able to learn, during the interview when you do that. I just wanted to clarify that part. So do we have anybody who is willing to volunteer to go chat with our physician who is involved in pulling the line out? Perfect. Wonderful. Here you go. So let's give it up for Shar. All right. And again, can you introduce yourself to the group and what you actually do in your real life?
Sure. So I work for a critical access hospital, and I'm the director of process improvement, as well as nursing specialty. I'm sorry. I'm a director of process improvement at a critical access hospital. So.
Awesome. Great.
Okay.
Thank you.
And does my physician have a name?
James.
Pardon?
James.
James. Okay. Awesome.
And you know him. So it's not like he's never seen you before, not particularly well, but
Sure.
he knows who you are.
Okay. Hi, James.
Hey.
I'm Shar. I don't know if you remember me.
I think so, yeah.
Okay. I work in process improvement. How you doing?
Not very well.
Tough day.
Yeah.
Tough day. Well, I'd like to visit with you about the process. Nobody's in trouble here or anything. We want to look at the process and see how we can improve it. So I was wondering if we could just take some time and go over your interaction with the patient from start to finish and just walk through the process. Is that okay?
Sure.
Okay. So tell me how you came across the assignment and just in your own words, if we can walk through it.
Yeah.
Do you mind if I jot things down, just so I can remember?
No.
And I don't know the job. I don't know, your job or the process at all. So I just want to see what happened today.
Okay. This feels a little bit of a blur, to be honest with you. It was insanely busy.
Okay.
Yeah, my attending sort of said we were able to pull the line from Mrs. Morris. I was a little bit apprehensive about doing it, if I'm honest.
Have you done it before? Have you done this procedure before?
I've done it like twice.
Okay.
Back at the VA. And, it's a bit difficult, actually, just thinking about it.
Yep, absolutely. Take your time.
No, yeah. And so it took me quite a bit of time to sort of get all of the equipment and everything else, all the little bits and pieces. Then I got, the nurse was nice and said that he would come in and give me a hand. And
did you know the patient beforehand?
Not really. I mean, I kind of knew her a little bit,
Okay.
but no, I wasn't like, we didn't have a really close relationship. No.
Okay. So you got the equipment together and everything, and a nurse to help you do it, and went into the room.
Mm-hmm.
So what happened then?
I had a conversation with her. I told her what was going to happen, and she was actually really, it's quite difficult to remember because she's quite excited about the prospect of getting out. And
so did she understand what you were going to do?
Yeah.
And
So
she was able to participate?
Yeah, I told her, I'm going to lie you down. I'm going to have you bear down for a second, and then it'll just be over like that. It'll be really quick.
Okay.
So she was kind of, yeah, she was excited about the idea of getting out, like I said, and we were joking around about what she was going to do in the weekend, and I don't know what happened. It's just, I don't know.
Kind of hard to remember everything with, what happened and stuff. So, was it, who all was in the room?
It was just the three of us, just the nurse, and Mrs. Morris, and myself.
Okay. Did you feel comfortable doing the procedure? You said you'd done it a couple of times before. Was there anything different about this time?
Yeah, I mean, I was a bit apprehensive, and then when, I took the Tegaderm sort of strip off, and I was removing the suture, and I was like, oh, that's a big line. Like, I had not seen something as big as that before.
Okay.
So that sort of put me on edge a little bit, yeah.
Okay. Okay, I don't know where to go from here. So you pulled the line out and applied pressure.
That's what I ended up doing, and then
And the nurse was in the room?
Nurse was there, but only for a second. Like
Okay.
It's just.
Only
Yeah,
for a second.
well,
Did he get called out, or?
Exactly. Yeah, I mean it was okay. That's the thing. It was just so weird in my head. Like everything had went so smoothly, and then I had my hand on the site, and it just looked like it was done. And then the nurse got the call, and so I said, "Yeah, of course, just go and do what you need to do. I'll look after it." And then it was just blood everywhere. Like I just don't know.
Blood everywhere. Okay. So when you went into the room, you had a conversation with the patient. The patient understood what you were going to do, and you walked through it. You had the supplies in the room, and it was all set up. Then what? So then you were pulling the line.
So
and then
it just started like there was loads of blood, and then the nurse had to.
It's okay. It's okay. We're going to talk to everybody that was involved. Again, we want to just look at the process and see if there's anything in the process that fell apart. So we want to.
I think it was my fault. It was my.
You think it was your fault?
Just thinking about it now, that when it was too bloody, and then I had to get another packet of gauze. And I lifted up my hand to open the next packet of gauze, and I think that's probably how the air got.
So you didn't have what you needed there, so you had to release the pressure to grab it.
I think that's what maybe happened, actually.
Okay, so you think that's what happened with the patient?
Mm-hmm. I'm sorry. I think that's what happened.
So we're going to look at it and see if, is there some process that we need to do. It sounds like you were in the room alone when it happened, which put you in a situation that was difficult.
Yeah.
Okay. What can I do for you right now? I want to support you and be here for you as well.
I'm not sure, just, I don't know.
as we talk to everybody and pull the process together, I'm hoping that we can get some ideas from everybody that was involved and how we can improve the process. Would you be willing to help us out on how we can improve it so this doesn't happen to anybody else?
Sure.
I really appreciate that. I know this has been really hard for you.
Yeah. It has been.
So once we write all of this up, I want to go over it with you, make sure that I captured everything correctly, the way you remember it. If there's stuff that you remember later, please let me know. Sometimes as we think about it and process it, we think of things that maybe we didn't think about at the time. How about any interruptions or noise in the room, anything that you can think of at the time? Again, anything unusual that was going on? I know you said it's really busy. So is it okay if I touch base with you maybe tomorrow and see if there's anything else that you remembered, see how you're doing?
Yeah.
Okay. I really appreciate you taking the time to visit with me about this.
Okay, thank you.
Okay?
Awesome. Give it up. Yeah, it's tricky, isn't it? It's hard and it's very unrealistic. But there's but there's so much learning. What other questions might some of you have that you really like to know that again we're going to fill out this list in a little bit to do that. But any other questions? Yeah. Mm-hmm. Mm-hmm. How was that, James? How was your shift leading up to that?
It was chaotic. It was very, very busy.
That is chaotic.
Yeah.
How many hours had you been working? And
Oh, well, yeah, I think I was on at like 7 in the morning, and I guess it was like 4 o'clock in the afternoon, so been on for a while.
Yep. Great question, but not a, overnight, been up for 24 hours thing. It's at the end of an 8-hour work. Yeah.
I'd be curious to know if it's normal for the attending to assign a junior resident a line pool without another physician there? Or, is that normally happening that they assign you this task to go by yourself?
What normally happens?
Well, I think after the fact we found out that I was slightly peeved that the other we had a discussion with the attending, and he also hadn't had a lot of experience pulling lines, so I felt a little bit set up that he'd given the job to me.
Well, who gave you the job?
My attending, the boss.
Yeah. Who had never pulled lines out before.
Yeah, so there's some issues there.
Yep, no, it is. That's an issue. Any other bits of information you'd like to know as we build out a lot of what the contributory causes were, towards this? Other questions people have? Yeah.
This was the first one we really heard about the blood.
Uh-huh. Yeah.
So there was no notes anywhere or anything, and I'm not sure I heard everything that he said, but it was disturbing emotionally to him when he saw all the blood.
Yeah.
And so it was a delicate situation, and you don't want to, maybe explore too deeply because it was upsetting to him, but that's an area I would want to maybe interview a little further.
And how might you do that? Going back to what Kelly said, how could you?
I'm learning now about the bleeding. I see this as upsetting to you. Is this a time when you're able to tell me a little more about that? Can we talk about that a little more?
And what would you have said if you were asked that?
Do you mean the actual bleeding of the
if she had said, "Hey, I want, are you comfortable going ahead and let's get more details about the bleeding"? Would you have been okay to talk about it?
Yeah, and I feel like perhaps it didn't come through, but we reached an agreement that it was because I released pressure.
Yeah, and then that's when you said, right, and then...
I felt like I knew that's where the air had sort of entered.
Yeah, because then you kind of had a real response to that. And
sure.
That's where he
feel
first
like
realized it happened.
Yes.
That's right. That is where he first realized it happened. But what phrase could you use to say, because there are some other pieces that might be useful here. What's the phrase that Kelly said? Tell me more. Right. Let's go back. Let's revisit. I'm going to start in the middle of it now. Tell me more about exactly what happened after you pulled the line out. And would you do that now? Will you just share with us now?
Just the facts.
Go really slow. You
pulled the line out, had pressure on the wound. The blood sort of soaked through this piece of gauze very, very quickly. So I realized I needed another piece of gauze. And because it was already open, I could just replace it. But then the blood started soaking the second piece of gauze. And so I didn't have any other pieces, like packets of gauze open. So I had to open another one. And so I had to let go to open up the next one. And that's how they are going.
And tell me more about what happened after that.
And then she eventually sort of fell unconscious, and I just sort of started screaming for help. And then there was a code, and then people started coming in the room, and then I just sort of dazed out.
Well, in the real case, there was a lot of throwing up. In the real case, it was a psych intern on the neurology service who was asked to pull the line out. Honestly. I mean, and that we know in a lot of places that is not necessarily uncommon, in terms of doing that. What position was she in?
She was lying.
Let's go back through again, really way back. How did you prepare her for it, in fact?
As I said, we had a conversation about what was going to take place, and she was okay with it. And so she was seated, and then I laid her down. And
what did you tell her she would need to do?
She was going to have to, at the point I told her to, she would have to bear down and turn her head to the side. And she did that, and then I sort of efficiently pulled the line out and replaced it with the gauze very quickly. And so I feel like I did everything correctly up until that point.
Yeah. So part of the trick is, as you hear stuff, and that's why I love it, Kelly put it on that slide, you can, when you're kind of stuck, you're like, I don't know to go where. Just go back to, let's go back to here, please tell me more. And then.
And I tried that, and he said it was really, a lot going on right at the time, very confusing at the time, but yeah.
And then just allow silence. That's the other part. Just allow silence. As he begins to recall more, you'll get a little more, coming out from that standpoint. Yeah.
So one of the things, I got a mic, thanks. So it's very interesting. It's a great role play exercise. So I'm a mortuary officer in the Air Force also. Wow, put that in your mind, right? And so we go through training, and we've done some of these role play things when we have to go tell a loved one, mother, father, whomever, that your son, daughter, brother, whomever has made the ultimate sacrifice for the country. And we talk about some of those things of body language. And what you don't ever want to say is, it's going to be okay. Because that's something that we naturally want to say as our words of comfort to each other. But what you're telling that person is going to be okay, and then that self-guilt that I have of, it's not okay. Because I killed somebody. I didn't mean to, but I killed somebody, right? So being very careful of the things that you say with that. There's another point I was going to go to, because you brought up some stuff here, and I'm trying to get it back, but just be very mindful of that, of saying that things are going to be okay, because they're not always going to be okay. And for that family member, it's not okay. They came thinking they're going to be saved and whatnot, and they're not.
I love that you said that. I think maybe this is what you were thinking, that she was very good at trying to express her care for him when she said it's going to be okay. Right. It's okay, it really is, it's okay. And I felt a little uncomfortable for you, Shar, because I know that when you're up on stage, because I was last time, you're trying to find the words, but maybe, it's funny because I don't even remember saying it's going to be okay. It's like, yeah.
Because
she's
she
not.
Wants it to be okay.
Yeah, she wants it to be okay.
She wants it to be okay.
The other thing that I noticed that was coming to your mind very, maybe repetitively, and that's, I almost said, and that's okay. See, we want to take care of each other.
We want to look at the process.
But you continued to say, we're going to come together. We're going to look at the process to see if we did anything wrong. We're gonna look at the process. I felt like pretty soon James was going to say, oh, so you think I did the process wrong or something like that. I felt like that was maybe not building comfort in him, and you maybe I felt like maybe he was shutting down a little bit because of her asking about or commenting about, we're going to look at the process, we're going to examine the process, make sure that the process was okay.
Yeah, the intent was to look at the process and not the person.
Right.
And
so that was the intent, but that's interesting.
Do you have any suggestions about that? Did anybody else feel that?
I agree. This is why it needs, you need to practice and practice, practice. The focus should be on learning what happened.
Yeah.
You know, and when you see the emotion, name the emotion. This is the last workshop. I can see you are really, really struggling with this. Do I have that? You seem really upset. Mm-hmm. And then the it's okay would be, it's okay to be upset. You know, you've just experienced, that's the part that's okay. It's okay to feel crappy and terrible and horrible.
Right.
But it may be a while before, or maybe never, that you really be able to put this behind you, because it's such a traumatic thing for them to happen. But I think to tell me more, just
tell me more.
Try to tell the story. In other words, the other way I think of this is, and kind of Kelly said is, when we're done with all these interviews, I want to be able to make a movie. Literally a movie from beginning to end and not miss anything. So I need to roll back the interview because, hang on a second, because one of the things I'd want to know is, when did you learn you were supposed to pull the line out? Had you had a chance to review the medical record? Are you aware of anything in the medical record that would indicate today might not have been a really, you know, all that stuff. That's why I had you review the medical record first.
Yeah.
You go in there with that mindset. You just want to play the movie. And start wherever you want to. I thought you were great. You know, how you started to, you got all the information, but there were moments in time that we still need to fill in.
Right.
And you kind of want to go back to those. And the tell me more, what was your day like today? You know, how is it determined, or how did you end up being the one to pull the line out? Can you share what that was like? And he has all that information. He would, you know, share all that. But I think that's the way you want to visit the quote, what's our process and policy later. You just want to know what happened. This is work as performed, not as the policy, you know, imagined. Does that make sense in terms of, it's really to just get a sense of what happened. And in the process of that, identify. Kelly, other ideas on your part kind of related to that? Because that's the trick here in terms of doing this.
Well, and I think you may ask a lot of questions that don't end up having anything to do with anything, but you don't know until you ask them. So asking things, how did he gather the supplies? You know, I wrote down earlier from the first interview, we had said the equipment was okay, so that's probably not an issue, but avoid anchoring on that because you only had...
It was an issue.
Well, and you only had the nurse's perspective that everything was in the room. So...
Well, he said he got the supplies.
Yeah.
But he's only done
But he would have gone in more details about, going back to what Kelly said, is you could say, describe the room to me. Where was the bed? What side of the patient, you know, where were you? Where was the nurse? Where was all this? And he would share all that with you.
Or if you hadn't pulled this line before, how did you know what to gather? Did you go to a procedure somewhere to figure out which supplies you were going to need, or did you have enough experience that you knew what you would need?
You know, so one of the things that I often, you know, as a commander, I used to have a lot of lieutenants. So lieutenants are O2s, or, you know, O1s rather. And they start off, they have, second lieutenants, O2s. They have no experience in reality. But when I look at you from afar, I see a gold bar on your sleeve or on your collar. And when I'm an airman who has 2 stripes or 1 stripe or no stripe on my sleeves, I see that gold bar and I automatically assume you know what's going on. When I come into the hospital as a patient, as a family member, I see a white coat. And I automatically assume you have all the answers. Whether you're a tech, whether you're a, you know, in the military hospitals, they have the techs that wear white coats as well. But whether you're a tech, whether you're a first-year med student who's in there, I know now there's a rank structure with the length of your coat, right? Whether you're an attending, whether you're a fellow, whether you're a resident. So understanding when you're doing that kind of role play and trying to get at the root cause, is you got to understand that person. So maybe you're the junior doctor, you have to also assume maybe he doesn't know a lot about this. And when you ask those questions, because I do a lot of process improvement in my normal military job called manpower. And so when I'm looking at things and I'm interviewing people, so side note here, as I'm talking to folks, I'm asking, what do you do in your job? How long does it take you to do your job? And if you've ever seen the movie Office Space, that's what I do. And so people are very reticent to tell me stuff. And so what I do is I find out through casual conversation. I'm talking about a lot of things that are going on. Some things apply to your job, some things don't. And as I'm doing that, I'm also going through the process, but I'm allowing you the freedom to speak openly. I come in very casually, and you're like, oh, this guy, he's just a nice guy. He's not going to cut my job.
Columbo.
Right?
Yeah.
So have that opportunity, have that space to just ask those questions that will actually lead you to process improvement, but it's not so directive and so sterile almost. Okay?
Yeah, yeah. So what other things would you like to know?
For the first time, we hear a little bit about James's relationship with the patient and that he didn't really know her, but he did have some depth of conversation to know that she was excited to get to go home that day.
Yep.
So I get, for the first time, you kind of get the sense that although there's somewhere in the notes that she really wasn't expected to be discharged till the following day, it sounds like there might be some urgency on the patient's part to get home. And what kind of climate did that create? Did that create for James a sense of let's get her going, and he didn't explore maybe the medical record to the degree that he should have to notice about the heparin that was given that day and just enough about what had gone on with her that maybe she shouldn't go that day. I don't know.
Yeah, no, there's that piece. There's also when it's busy, chaotic, pressure for beds. Right. So that you can explore and find out more, in terms of what it was like. Was it fully full? Were you having trouble getting patients in and out? Describe for me a little bit about that. And where do you think the bleeding was coming from? And why? Under plasmapheresis, she was heparinized. They don't reverse it. The reason the note says what it says is because they wanted time to allow the heparin to be metabolized so she wouldn't be anticoagulated. So he pulled a dialysis catheter out of an anticoagulated patient. And so what other things are helpful to know? Because we're going to pull a lot of this stuff up when you look at all the different contributory causes. Yeah.
I think one thing he said that just came to my mind, I think he said she was sitting up and then he laid her down.
Yep.
So procedurally, that apparently was a little oversight on his part.
Well, no, he laid her down as part of the normal process to pull a line out on somebody to prevent this. She was sitting up. He laid her down per his training to make sure she's flat.
Oh, he
when
did?
You pulled it. Yeah. Yep.
Okay.
Yep.
What about his relationship with his attending? Remember he said something about...
Yeah. With the attending, it told him to take it out.
To just go in, but it was just kind of tense. Yeah.
Yeah. What was your relationship like with the neurology attending?
It was okay. Yeah, as I said, I think I was a little bit peeved afterwards when I found out that I felt like he'd maybe set me up in some way because he hadn't pulled a line out before, but it was okay.
He was sending you to do something that he himself...
Exactly.
Yeah, so that's a big issue, right? I mean, talk about a...
Did she have any labs drawn today? What were her labs today? Like an INR or PT
no.
or anything?
There were no labs. No. No labs that day. I'd answer that one for you. I'm not sure.
Okay.
What other really important bits of information worthy of kind of teasing out here again?
Well, I was just wondering, because he had a nurse that also had no experience, and he just kind of randomly went by somebody and said, "Hey, will you help me?" With so, I guess you would wonder if the nurse had any experience, if maybe you were the attendee, since you had lack of experience.
Yeah, and so part of it is, hey, I need to pull this line out. Can you help me out? And they say, yeah. They had a good relationship. Yeah, of course I can help you out. Because at that point, what I would say both of them is at that level of unconscious incompetence. They didn't know what they didn't know, so they're often not going to ask this. And we need to explore that a little bit in terms of when you have two people that are like that. That's going to be that's a human factor. There's all kinds of things to think about that, right?
Does he know if he finds himself in that position, what is
Mm-hmm. So there's that piece. You know, did you feel comfortable going up the chain of command if you weren't uncomfortable? The same question for the nurse. I agree. What other things would you like to know?
I think there was too much focus on the task
Mm-hmm.
and not about the patient and really like knowing the big picture.
Mm-hmm.
Which I think, I'm sure is true with residents. It's the same with nurses. You're very task focused depending on where you're at in your experience level. And
mm-hmm. Yeah,
so
that's a good point.
But lack of empathy because you're not.
Let's
it's
go
a
back to
task.
some of the questions that you could ask about, you know, this particular process that you would want to know.
There wasn't any informed consent in the sense that, you know, it wasn't told the patient that this complication could happen. This is what we're going to do. There wasn't. Things were just sort of rush. It was almost like the perfect storm.
Right. Well, and so part of that question would be, do we get informed consent when we pull lines out?
Yeah.
A lot of organizations, they won't. I mean, for pulling them out, they do to put them in, but not necessarily to pull it out. Yeah. What else might be a burning question that you might have for the organization for this piece, from both the nurse and the junior doc? Is there bingo?
Protocol.
What if you would ask the nurse, is there a protocol or what have you? They would say, absolutely not. We do not have a protocol to pull lines out. And that would be true at the time. A lot of organizations have protocols to put lines in, but there are no protocols to pull them out, even though there's a lot of evidence out there to suggest those are super helpful. You know, Peter Pronovost from Hopkins wrote an article about they had, I think, 6 air embolisms pulling out lines in the course of 18 months in their ICU. And that's when they really had to step back and go, oh my gosh, you know, there is not that piece of it. The other part, again, as we move towards lunch, that might be helpful is, did you practice this in simulation? You know, how were you trained? You know, it sounds like you pulled lines out before. Tell me about, you know, what you were taught and how you were trained, because he did say he followed what he did before. So that might be a good way to kind of explore. That's right.
And I thought that was great.
Yep, absolutely.
It's a great way to see the difference.
And do you remember what the answer was? Because she did ask, what was different about this? The blood. No, before that. This thing is huge, and it is huge. Have you seen a dialysis catheter? These things are massive. You know, when you look at that and do that. So let's throw out, now that you've heard this piece, well, and there's the other part there, which we could get into more, but I'll share it with you now, because after lunch, we're really going to want to get into the confirmation consensus piece. The note that says, don't pull it out to tomorrow, was not in the chart at the time he pulled the line out. There was no phone call to the unit to say, we're done now doing plasmapheresis on Mrs. Morris, but she's still heparinized. It's going to take a few hours for that to be metabolized, so just make sure you don't pull the line out tomorrow. So there's no verbal handoff. There was no clear communication. In other words, the question Kelly asked is, did everybody have the information they needed to be able to do this? You know, they didn't have that part. So before you step down and we get into this, what's your name again? James. So talk a little bit about, she made some really good conversation, some other stuff with it. How did it feel from your standpoint?
Oh, yeah,
in
absolutely.
terms of the comfort level? Because
Yeah,
we know what her
was.
goals were and what she was hoping for.
Yeah,
So.
and I don't know if you saw in the audience, but as soon as you came up, you sort of like touched my leg, and it's just a really comfortable way, and I thought it was very sort of personable, sort of, because you could see physically I probably wasn't doing well, and throughout the interview you had a good amount of physical touch that, you know, worked for me. I really appreciated that. And then you were doing a good job of asking open-ended questions. So I was actually surprised when you had that break and said, oh, I don't know where to go next, because I felt like we were getting places, and I felt like, oh, she's just going to keep going. She's going to tease more information out of me.
My mind went blank.
Yeah, right. But I thought you were doing a good job. And then the only sort of thing I would say was when it was clear that I had sort of had a bit of a realization moment about what happened, you continued this sort of like more technical process-driven sort of talk after that happened, instead of just letting that sit for a little second and just letting because that's a big, big moment for this guy to understand for himself. So make sure that that has been given adequate attention before you go on to those next steps. That's what I would have said.
Mm-hmm. Yeah, no, I thought it was really good. Yeah. Any other final things you want to toss out? Otherwise, I think Kate will go to lunch, and then maybe after a half an hour getting into it, we'll kind of kick in and we'll start. Kelly will bring up, and we'll start doing some of this stuff. You know, where we're then going to have the confirmation consensus meeting to see if we can get to some consensus of all of what happened, and along the way identifying some of the contributory causes.
Very, very good. Lunch is located out the far door and right to your left. So grab it, come back in. Thank you.
Woohoo! Thank you, Shar.